Next topic, we have been throwing the word ERCP around since morning. So as you all know, ERCP is endoscopic retrograde cholangiopancreatography, and we will be having Dr. Basumani speak on it. Can we have the video please, Homera?
Endoscopic retrograde cholangiopancreatography, or ERCP, is an advanced endoscopic technique combining endoscopy and fluoroscopy to evaluate and manage biliary and pancreatic disorders. An endoscope is passed into the duodenum, and the major papilla is cannulated using a catheter or sphincterectomy. Contrast dye is injected into the bile or pancreatic ducts, allowing cholangiograms or pancreatograms to identify strictures, stones, or leaks. ERCP is mainly therapeutic. Procedures include sphincterotomy, stone extraction, balloon dilation, brush cytology, and stent placement for benign or malignant obstruction. The most common complication is post-ERCP pancreatitis, with other risks including bleeding, infection, and perforation. In summary, ERCP remains an essential endoscopic tool, reserved primarily for therapeutic management of biliary and pancreatic disease.
Dr. Basumani is a highly regarded patient-favorite gastroenterologist based out of Chennai. He is proficient in therapeutic endoscopy, including ERCP and EUS, with over 30 years of experience. He practices at Connect Care Clinic at KK Nagar and is also associated with Apollo Hospital. He is a public orator and a media person of repute. Over to you, sir.
That picture was before I joined Muller, I think. No? I've got more gray hair. Yeah. Right. So much of the setting has been, already, is there. So team sport, hierarchy is flat. A doctor, nurse, technician, attendant, everybody is same in a procedure room. Only the patient is of paramount importance. So all those principles have been set. I'm happy for that. When I'm doing colonoscopy, how many pairs of eyes are looking for polyps? Twinkle. நான் கொலனோஸ்கோப் பண்ணுறேன் எத்தனை நான் மட்டுமா பாலிப் இருக்கான்னு பார்க்குறேன். ஸோ த ஹோல் and I expect my nurses, everybody, one would look at the patient, all others are looking. So it's all about imaging, visualization, identification, and helping each other, holding each other, looking after each other. So Vidya said it is endoscopic, that means we use an endoscope. Retrograde means we are going from the drainage point rather than the origin. So radiologists go through the origin of the bile duct by piercing the skin and going into the liver, but we go from the drainage point, and it is mainly for treatment. As we said, diagnostic ERCP has no more place now, but we use both the endoscope as well as the fluoroscopy simultaneously. We use EUS, we use cholangioscope, and so many things. My mentor, Dr. Ravi, he calls it endoscopic radiographic cholangiopancreatography, because radiology is as important as the endoscope here, because you need to look at the images all the time to guide. But my take is, it's the ego removed colleague's performance. There should not be any ego on the part of anybody. A senior nurse should not trample over a junior ERCPist. And any ERCPist has no right to muffle the voice of the team. So it is, there is no ego, there is no place for any ego in ERCP room. And in any sport, we need to go with a winning mindset. Oh, it's a difficult case, I'm going to have a tough time. No, that is not the way you start the ERCP. You prepare yourself. Preparedness is half victory, and then the winning mindset. But accept what comes like a good sportsman, and then there is always another day, another way of doing it. Call for help, postpone it next day, or Patta is here, he can put a wire through the cystic duct, and then you can finish it off rendezvous another day. And even if you are a endoscopy nurse or a theatre nurse, ஓடமும் ஒரு நாள் வண்டிக்கு வரும், வண்டியும் ஒரு நாள் ஓடத்தில் போகிற மாதிரி ERCP can happen in operation theatre as well. So even theatre nurses need to be familiar with this important procedure. Next slide. So it is one of the riskiest procedures for any interventional gastroenterologist, and most of the risk comes from the pancreatitis, which is like a bile leak. All those pancreatitis only loom large in the memory of any ERCPs. All the patients went home the same day, we forget. But one who stayed in the ICU or one who died, they linger long. They haunt you. So if you are doing 100 ERCPs, you are likely to have 5 post ERCP pancreatitis, and one of them might be very severe. So we should not do ERCP for soft indication. There should be a definite therapeutic intent. So this is how the anatomy, which we all familiar with. If you are working in transplant center, we will be even keen on intrahepatic anatomy, but mostly we should focus on the extrahepatic anatomy. Next one. This is how it looks internally, and you see the major ampulla on the lateral wall of the second part of the duodenum. Next slide, please. But in real life, it doesn't look that neat as the cartoon. Look at the ampulla. No, it's like all the haircut. No, kuru cut, kudumi, all those. No, so different types of ampulla. No, there is a normal ampulla, there is a hanging ampulla, there is a wrinkled ampulla, there is a creased ampulla, and there is a distorted ampulla. No, sometimes Dr. Ravi sir says, the ampulla looks like this. No, like with a tumor, head of the pancreas pressing into the extreme. So we have all types of ampulla, and again. Like the previous speakers said, no, Anita, if she is not looking happy, then that is going to be, if the sister looks unhappy looking at the ampulla, then that is going to take longer time, and we can always alert Vidya to intubate the patient rather than, because if you are going to be there for 45 minutes, it's difficult for them to hang on with propofol alone. So these are the standard indications. Fortunately, 2/3 all over the world ERCP is done to extract CBD stones. I think there are 2 sessions discussing the nitty-gritties of that. We talked about bile leak and other indications, mostly palliation of and diagnosis of hepatobiliary pancreatic malignancies. Next, please. So, like I said, the highest adverse effect profile compared to all other endoscopic procedures, and the cost, the patient expecting to go home after paying the package, if they stay even in ICU for 3 days or 5 days, forget the odd patient who will stay for 30 days. You can imagine the disproportionate angst, anger, and misery a patient is going to go through, and the family going through. Next, please. So even though it is one of the top-notch procedure, the quality among practitioners vary widely. Next, please. And it all depends on the volume of the center, and next volume of the unit individual. No, so like Patta said, 606. The more you do, the percentage of complications fortunately comes down. Next, please. So if the success is a team game, then more successful teams have lesser complications. So that's why when you are consenting, I think you need to quote your own team's complication rate rather than from the literature. Next, please. So if you take the example of post ERCP pancreatitis, it may be due to the patient factor, which we cannot change much. But much can be done about the middle column, about procedure related factors. No? So if there is a difficult cannulation, have they given ringer lactate and NSAID suppository, have you adopted alternate technique quickly, with the thinking, don't try a same thing which has failed 3rd time, 4th time, but Matthews, you need to think differently. And this is where the experienced endoscopy nurse or technician, I think, all of us who do ERCP will know that if Anita is for Patta, then it is more, I will say more than Anita and Patta, our technician or assistant is more to us. Nobody can be a successful ERCPist if they don't have a skilled technician who works along with that in a parallel level, not as a junior. So I'll hate the word doctor's orders. Those words should be thrown out of our dictionary. Doctor's instruction request is much better, I think. Next, please. So these are the important things that as our nursing colleagues should focus on. What should be the factors that we should address before ERCP? Because if somebody comes with the car and the wife cannot drive, they think that they can drive back like that. So how they will reach home or referring hospital. ERCP is often done in a center and they come from another hospital or another part of the same hospital. So we talked about solids and liquids up to 2 hours, and we have to look at the comorbidities. If there was a failed ERCP or previous ERCP, what happened and what are we going to do today? And any surgery, many times we have put in the scope and then realized the patient has had a previous gastrectomy and Roux and Weil loop and things like that. So these things should be never event happen. So sometimes the extraction balloon are made of latex, so that can be checked. Sometimes you give Buscopan to a patient with glaucoma. So all those minor points should be addressed. But more importantly, the cardiologists think that as long as the coronary circulation is intact, nothing else matters. But it does matter to us, so we need to, next please, ask if they are on bleeding causing medications, and these are the stopping rules. If in doubt, discuss with your doctor or discuss with the prescribing cardiologist. Next please. So at ERCP, so it's frustrating to find that the cannula in the ward is not working and then you need to start all over again. The working cannula and pre-procedural and pain level. Now we said about pain before cholecystectomy, after that. Now this also helps. What is the pain now and what is the pain after the ERCP? If it's a new pain or more pain, then things are not going in the right direction. So ask about pre-permanent. This is a good checklist before ERCP. Next please. Next please. And during ERCP, so it's better to place the cannula near the forearm or hand rather than the antecubital fossa. The patient lies on either left lateral or on the back. So wait till the anesthetist or the team gives a signal to close them up. Don't put a bite guard for 10 minutes before the procedure starts. It's unpleasant to the patient. And if there is difficulty in intubation, you may need to adjust the patient neck and then facilitate the intubation. Just gently reassure the patient rather than put your weight on. And talking about putting weight on, you already have a lead apron and you should be radiation sensitive, because the more close you are to the source of the radiation, more exposure. Also ergonomics, don't lean, don't go into because it can be a 45 minutes, even 1 hour procedure, and all of us know that arthritis and musculoskeletal problems are a major morbidity that affects people working in endoscopy. So after ERCP, I think we should clearly follow the institute protocol of monitoring. And is the patient awake, fully awake, or do they need any reversal agent? Inform the anesthetist. And it is an endoluminal surgery. Surgeons use laparoscope and knife. We use wires and cannulas. So it is a surgery. So post-operative nausea, vomiting, and pain applies to this procedure as well, like gas retention, even though CO2 has controlled that problem. And if there is any concern, just like the post-lab complication, we need to alert the team, especially the medical team, to come and review. Next please. So ERCP does not stop there. We need to follow that. What is where did the patient go? So most of the time they cannot sign a legal document because the son-in-law should not come and get a will signed at that end after the ERCP. Diet as tolerated. Even though we say clear fluids, there is no scientific evidence. Some of the lab coli patients have eaten masala dosa 2 hours after. So like that, we can allow the patient to modify the diet as tolerated, but educate them what they should watch for. And my personal thing is, if you have time, always ring the patient that evening or the next day morning, if they are doing well, because with the complication they might have gone to another hospital losing completely confidence in you, and you may think your success rate is 100 and complication rate is 0. Yeah. So, and don't forget the stent removal. 5 years later they come and they say, nobody told me to remove the stent. So this kind of follow-up is very important, because ERCP does not stop at 2 or 4 o'clock at that evening, but there is a continued care. Next please. So we should know what you are doing. It is a team sport, and you need to ask, talk and communicate. Silence is very costly for the patient. So if things are not going wrong, Please alert the ERCPs that we have tried enough, let's give up for the day. And there is always another way, I said PTBD or trial another day. So communication is a key. This is a non-technical skill that we should all get in level with. No, I repeat, hierarchy is flat in a procedure room. And be prepared, and when things go wrong, no, then that is the time not to throw the handle. No, so I told you so, so you never listen to me like that. Not at that time. No, you remain calm, sort the things out, and you can always have a debriefing later. This applies both to doctors as well as the nurses. And so be resourceful and innovative, and then see whether changing the cannula or changing the position can help the success of the procedure, and share your experience. I think it's very important that if a particular technique, if a particular maneuver, a particular tip has helped a patient, share that with your colleagues so that it will help other patients in need in future. Thank you. Thank you for your attention.
Fantastic talk, sir. Can I just add that do we have to sensitize the nurses about the need for antibiotics? Some of the procedures you may need to give prophylactic antibiotics.
Yes, sir.
So maybe if they know that it's going to be started right away, then probably they may have to start the antibiotic in the ward or have to send the antibiotic to the ERCP suite. So antibiotic is something that has to be remembered. And sir did touch upon, so I just want to re-emphasize that the post ERCP period. So the main three things that the nurses have to look for is main three complications. One, pancreatitis. Two, bleed, because they are going to cut the ampulla, it may bleed. Three, they are going to introduce some wires and cannulas from outside, so obviously infection. Look for these three things. Severe pain, the patient is having back pain especially, you have to think of pancreatitis. If there is tachycardia, think of either infection or bleeding. So you have to look for these three things at least: infection, fever and pain, which means it could be pancreatitis or some complication, could be anything. So these are three things probably the nurses have to look for in the post ERCP period.
And don't forget, pancreatitis can happen 8 to 10 hours after the procedure. I think that's why the next day phone call is as important as the evening discharge status of the patient. Sometimes it takes hours before the pain and falling ill manifests.
And don't forget to, sir did mention about that LNP, make sure that the patient is not pregnant. If the patient is pregnant, she shouldn't be going straight ERCP.
It's a different consent and a different precaution we take if it is absolutely indicated. But don't screen a patient, fluoroscope a patient without knowing the pregnancy status.
So we had a difficult situation about 6 months ago. A 24-year-old girl came with cholangitis, and an ERCP was done, stent was placed, and patient was referred for lab chole. At that time we discovered that she was pregnant.
Gravid uterus.
Yeah. So it does happen at times. But I feel that when the patient presents with cholangitis, the life of the mother takes precedence over the fetus.
Doing ERCP, knowing that she is pregnant is completely different, because you are counseled everything, because we can take all precautions, and then the pregnancy can be viable and even without any major malformation. But there are radiological guidelines, and radiologists will help us to get a very informed consent. But that is not acceptable.
One more thing I would add is, just like lap cholecystectomy, pain is the key symptom post ERCP, which can pick up pancreatitis, perforations, and then infections. I think that pain is the most important.
Yeah, so you have to understand that the amount of radiation that the fluoroscopy gives is 100 times or many hundred times more than what your chest X-ray is going to give to the patient. So you cannot take fluoroscopy lightly, because we don't know how many fluoroscopic shots is going to be required. And if the patient was pregnant, especially early pregnancy, then it's something very serious. So do not take fluoroscopy lightly, especially in terms of pregnant patients.
I think Hepsi is waiting to facilitate me. Come, Hepsi.
So, Hepsi and Dr. Basumani are old partners in crime. So, I now request Hepsi, our endoscopy nurse, to felicitate. Yeah.